Okay, class, we're going to start discussing Chapter 2, CNA, Foundations of Resident Care. Okay, again, I'm going to go over the chapter and the very important things I want you to underline. You might see them again, hence, all the way. But like I say, every word is important. Read before and after, especially any of your bolded topics. They're liable to be tested again, especially on your CNA test. I don't know what's on your CNA test. They've got a huge bank of questions that they use, just like nursing questions. I mean, they've got a huge bank, and they'll pull out from there. But this is your foundation. This is it. This is the whole book. But this is where we're talking about foundations of resident care. So, communication. It's the process of exchanging information with others. In healthcare, we need to know, and we touched on it, chapter 1, about verbal communication. Underline is using spoken or written words. We learned in school that it was all about verbal when we say talking or sounds. But in healthcare, it's also written words. Nonverbal communication, we all know that's not using words, gestures, my hands go on, everything, you can tell, even people's attitude, everything. They can be just a smiling, but it's something that's going to tell the real attitude. Page 84. This is a great communication tool. If somebody's had, I don't know, maybe they got just plain old laryngitis. Maybe they've had a stroke. Maybe they can't talk or speak your language. But page 84, that is a communication board. They actually, a lot of people, these are the symbols across the board, all the states. I mean, all the countries can look at it and say, okay, I need some water. Wife, daughter, I'm not sure if they'll catch that, but it's a person. But that's what they'll be using, a communication board. And that's to help with your stroke patients. But as we know, communication is important. If they're speaking another language, we need to get an interpreter around so they can tell us what they're saying, especially on legal paperwork. You're not going to sign anything just because they can. You can say sign here real easy, but they need to know their rights and they need to know what it says. Nursing assistants also make brief, accurate oral and written reports to residents and staff. Careful observations are used. Anything that endangers a resident should be reported immediately. Some things you can, take care of your patient, do what you got to do, and maybe take a, pad. I actually use these little bitty pads, and I don't even see none, but they are wonderful. You put them in your pocket, and you write down the date, and you go for what you know. I don't see any, but the little bitty ones, they look like a little notebook, but they're so small, and they fit in your pocket. Yeah, I usually have them. They've been in here, I'm sure. But that is the best thing to use. Or if you ain't got that, a piece of paper folded in hand. Just something that you will be able to write information down that you can remember. What you think you can remember from patient to patient. You won't believe how much you can forget. So write it down so you don't leave your patients hanging, waiting on something or trying to report something that you wrote down. Make sure that happens. But always report anything dealing with falls, chest pain. That's something you don't wait on that. You go tell them I got chest pain. Severe headaches, trouble breathing. They could be having a heart attack, stroke, lung failure. Abnormal pulse, respiration, and blood pressure. How are you going to report it if you don't know what it's supposed to be? So you got to know your vital signs. Change your mental status. A lot of times you'll notice your older people, they get catching UTI so fast, and I don't know why, but it goes septic very fast. They'll get confused. That means it's in their bloodstream. It's how bad it's done got. And they get confused. That's probably the first thing y'all will notice in your patients. You'll start seeing that rather quickly because you know your patient. You ask them something and they give you a weird answer. And I know my friend was doing everything the nurses were saying. They didn't catch on, but I forget some crazy stuff she said to me. And I was like, I went straight to that nurse's station. When I got out of there, I said, she's confused. You know, she'll follow instructions, but she's back there confused. She's saying some weird stuff. She thought we was in the casino. She thought we was in the casino, talking about what kind of hotel is this? And anybody else might have laughed at it and thinking, you know, but she was for real. She was for real. The other thing was she got up to use the bathroom. And I was like, you gotta use the bathroom? She said, yeah, I gotta pee. And I'm like, don't you have a catheter? Yeah. I'm like waiting for her to discern that she ain't gotta go pee, that she's got a catheter, she can't pee. So she kept walking. I was glad she was up walking because she had also got pneumonia in the hospital. So, you know, they wasn't telling her to get up and move. They was just letting her lie there, which is just not any good for anybody to lay there anyway. Anyway, so I was like, well, you got a catheter, right? Yeah, I just got to use the bathroom. So I thought she had to boo-boo. So I'm like, okay. I said, do you have to boo-boo? Or probably said something different. But she was like, no, I just got to pee. I said, you got a catheter? Okay. Like, she just wasn't getting it. And I was like, well, at least she's standing up and walking. They got her up. Then she sat back down, and I could tell she was just confused. She was like, you got a catheter. But she, that's why I said, the nurse came in there. She did her albuterol treatment. She took her meds. You know, you didn't talk to her. They gave her meds. Didn't really assess what, you know, is she there? And she might have answered all the questions correctly, but somebody that's there knows your patient, just like y'all are going to be. You're going to notice it. Severe weakness or sudden weakness or loss of mobility, that could be a stroke. High fever, loss of consciousness, change in level of consciousness, bleeding, of course, any change in their conditions. These are things to report. Bruises, abrasions, or other signs of possible abuse. Make sure if you're just getting on that unit and you're just getting hold to your patient, that needs documented. Because or else, if you don't document it, you don't tell it, then guess what? Guess who did it? Because the next CNA is going to look at it too and see why, hey, they're going to say, I did not do this. And look at this here. So make sure you do that, because if somebody's coming behind you and they're going to just assume you did it. Because the last person didn't report it, you didn't report it. So who did it? It's going to be the one who reported on. When we're making reports about residents, remember to include all your resident information. When you are talking to patients, if they can talk, if they're not had a stroke where they cannot talk, ask as many questions as you can. You want to get the overall picture of what's going on with them. Try not to answer with a yes, or ask a question with a yes or no. Don't say, do you like vegetables? That's their, I thought that was their example, but do you like vegetables? No. Do you want vegetables? No. You just say, what kind of vegetables do you like? And they may think about it and come up with some vegetables. But try not to do the yes and no questions. For you, as a CNA, you must always greet the residents by his or her preferred name. Introduce yourself. Focus on the topic to be discussed. Face the resident while talk with the resident, not other staff members. A lot of people will sit there doing for their patient while they're sitting there having a whole conversation with somebody else. Sometimes that's okay. Most of the time, if you're not involving your patients, it's not okay. Your patient needs to be in the conversation too. But otherwise, you need to be talking to your patient. Listen and respond when the resident speaks. Praise the resident. Smile often. Encourage the resident to interact with him and others. Don't bring your problems to work. You are there to encourage that patient, and hopefully you can encourage them to do better, do more for themselves, get up out of bed, just something that they haven't done. You want to help them do that. Be courteous. And tell the resident when you're leaving the room, okay, I'm gone. What if they're blind? You just walk out of the room. See ya. I always just tell them I'll see you later. And before you walk out that room, which will help you more than anything, ask them, do you need anything in? Okay, I gotta go. I'll be gone for a while. And I always say that, because they'll be like, oh no, I'm good. But you let them know I'm gonna be gone for a while. That's that little ticket to say, oh yeah, I better come up with something or not. But or else they need to be the one in 15 minutes calling you back. But I always tell them, I'm gonna be gone for a while. Anything else you need me to do now? They're gonna take me or something. You know, I make them. You know, not that I mean to be gone, but you make sure that you tell them that so they can get something out you, or else you'll be back in their room. And if they're a good person, they'll think, she said she'll be gone a while, so you know they'll wait until you come back. So try to do that. Some of them don't pay you no attention. They don't care what you say. They'll call you back in 15 minutes anyway. But those that are a little cognitive feel for you. They know you got 10 other patients down the road. And they're okay. Don't refer to them again as sweetie, honey, dearie. You want to call them by their names. Know the difference between objective information and subjective. Objective is something that you can see, hear, touch, or smell. Underline it. See, hear, touch, smell, measure. Any of that kind of stuff. Those are what we call objective information. Subjective, I always say, and remember, the subject thinks this. The subject says this, I can't see it. My favorite one is pain. We don't know in most healthcare, unless you are a known drug addict or drug seeker, we are not going to bother you. You say your pain is 10, we're going to try to give you medication that will cover that pain of 10. And most people, you know, some people really feel, say, pregnancy pains. My sister, she barely needed any medication. Me, I needed the whole cabinet. I wanted the whole cabinet. But you got to ask them, you know, how's your pain level? Some of them over-exaggerate. Some people actually are feeling that pain at 10. Maybe they're not just looking at. Sometimes those vital signs will tell on if their heart's racing. If you can tell somebody's sweating, pulling their hair, you know, pain is pain. And I can tolerate pain better than the next person. I used to say that when I had headaches until I really got a migraine. I used to make fun of people who go on in medication for a headache. I guess I never had a real one. I've been, you know, had a little slight headache, but when I got a migraine, it was over. I'm sorry forever. Lord, I'm sorry for ever talking about anybody in their head. Because I would mess with them, and you just want some medication. Can't handle nothing. You're just weak. But I'm over that. But whatever your patient says, if they're in that pain, make sure you get it reported, because and maybe you can help them out. If there's, I got a little back pain going on, leg pain, maybe you can readjust the pillow, turn them to their other side. Something that you can do as a CNA, and then tell the nurse they can shoot down with some medication. But that's subjective information. Nausea, and the children get us all the time. We don't know if they're nauseated or not. They may be. Sometimes they're not. I'm sick, I can't go to school, I got to throw up. You know, or they get out of class, I got to throw up. I'd be like, okay, get out of here. Or get my trash can and sit beside them, one. But, and I tell grown people that too. You know, I work in detox, and a lot of times through their detox, they're going to throw up. I'm like, don't not come tell me that. If you don't get you, go sit by that trash can or something. Because I have actually been thrown up on a man walking, coming and tell me he was nauseated, had to throw up, and it was straight all on me. And that was it. That was it. I'm a little phobic.
Yeah, I bet.
And I'd be like, oh, no, go sit down over there. And I go get my trash can, or, you know, the wash pan, whatever. You're getting away from me, because I don't want to throw it up on. But I'll give you some medication. But there's medication for nausea that'll help you. Sometimes you need it out of there. You know, your body says, I don't want it. So let's get it out. Don't try to hold it in. Just get it on out, and feel a lot better. And be like, are you okay now? Yeah, hallelujah. Because nausea is no joke. That's the worst feeling I have ever. I do not like nausea. I can take any other. I can take pain better than nausea, but I don't want neither one of them. But watch out for that. So subjective is that person, how they feel. Dizziness. We can't really tell that they're dizzy, lightheaded. They look it though. They have an unbalanced gait. They're weaving. Then they fall. Those type things. But we didn't know that they felt dizzy or lightheaded. That's something they have to tell us. That's subjective. From the subject, that's their information. Everything else is objective. Something we can see. We see them sweating. We see them fall. We measure their vital signs. We see and can measure any of that. We can feel how cold they are, how hot they are. All that is objective. And they break it down. You can sight. You can see discharge, swelling, sunken eyes, hear. You can even walk into a room and know where there's there's a lot of children making a lot of noise. To me, that's like anxiety. For a mental patient, imagine what it would be for them. And I'm a lot of psych nurse, but imagine you're got a migraine and going into that same thing, or just noise. TV's up too loud. Turn the TV down, and you wouldn't believe the amount of relief you can give somebody, or calm them down, or just get them out of that area, and that's a type of relief as well. Touch, hot, heat, cold, smell. You can smell body parts, and you can smell gangrene. Would you ever smell it? You'd be like, you can tell it every time you walk in somebody's room. You know that they've got some dead skin, and that's what gangrene is. Incontinence, and people who are not being taken care of, you can smell as well. But not just plain incontinence. It's kind of in a bad place to me. But underlying this definition, incontinence is the inability to control the bladder or bowels, either one. A lot of people can't control their bladder, but they can tell you that they're having a bowel movement, and get them through the toilet, or else they might go on themselves. But I would rather you let me know about the bowels, because your urination ain't so bad as cleaning up after a bowel movement. But try to get them there. A lot of people are incontinent urine, but not so much their bowels. Also, make sure you're writing your notes, anything that you need to come back to later. We do not take a medical terminology class in this part. We don't even have such a section, but this is your little section right here on page 22, right up under figure 2.3. This is our medical terminology here. Now I'm going to shoot you to another page that you need to learn as well. NAs will learn medical terms. All that is, a lot of your words are stuck together. It means something when you stick them together a certain way or with certain words. So they are affixed to your root word. Root word could be cardio. It means hard, something hard. So that may be what it's attached to. The root derm, which means skin. So if I got dermatitis, itis means swelling. So I've got swelling of the skin. So give me another itis. I know y'all know some itises. Hepatitis, that's swelling of your liver. You said hepatitis. Any other itises? Very common elderly itis. And they're going to tell you they got it all day. Come on, what's the most elderly complaint? Anything with itis? Arthritis.
Oh, yeah.
Oh, my goodness. Y'all both are fired. Arthritis, that's the most common itis you're going to hear. Anything, that's ortho meaning joints, itis. So you got swelling of your joints. Give me another itis. Come on. Y'all done heard it. Y'all got children. You got friends. They done said they was staying out of school for something. And I probably was an itis. Tonsillitis. There you go. Gastritis. Conjunctivitis. This is pink eye. Bronchitis. I'm sure your friends got bronchitis. Bronchial tubes. That's swelling of your bronchial tubes. All the itises. There's something swelling. Something swells, and then you get an itis. Whatever it is, it's itis. So I'll know that itis is swelling. Every time you see that word itis, it's swelling. Also know this, what Brady means. Underline that, Brady means slow. Does anything, y'all know what tachy means?
Tacky.
If I got bradycardia, what's tachycardia? Fast. Anytime you say tacky, it's fast. Tachycardia is fast. Brady means slow. Okay. And get that, because One of my young ladies told me that was on her CNA test. Just the simple words there. We do learn a little. They don't stress it, but you need to know, especially your itises. You need to know that means swelling. Any body part that's swelling is going to hurt, ache, because it should be swelling into other body parts. So ibuprofen is a wonderful thing for itises. Pathy means disease. So the root neuro means nerve system. So neuropathy is the nerve disease or disease of the nervous system. Put those words together. Pathy, they use a lot, depending on what's going on with your body. Neuropathy is how we say it. When speaking with residents, though, and this is why we don't go through that class, simple non-medical terms. Underline that. Should be stored. But I want you to turn to page 242. This is what you do need to learn.
What did you just say earlier?
Simple non-medical terms. That's how you talk to your patients. Page 242. Let's all scroll back there. This is a list of wonderful words that you will need to know, and you will become familiar with them because they will use these all the time in little things that you'll see, a little report that you'll see when you look at care plans, when you look at their MDS. When I get a new patient, I don't know nothing about them. Hopefully they've got an MDS that I don't have to do. I'm the RN. I'll probably have to do one. Most of the time, the facility sends you an MDS, then you have to do another. And make sure that they're not fooling you, but you know, that is where RN in a nursing home, it will probably be your DON. No, that's a lie. It'll be the one right up under her. That's a supervisor one. No, but they're going to be the ones doing it. Yeah, the RN does it though. The RN has to do it. But everything that goes on with that patient. So we're going to accept them, and we're going to have to check all that off and add if possible or not. But I always get, and even for a CNA, the easiest thing to do is go look at their care plan. Go look at their MDS, and you'll always know what's wrong with them. Because sometimes you don't get a good training. Maybe you just walked in this facility as, you know, you just came to help. That's your easiest. Find a care plan and look at what's wrong with the patient first, and then start your day. And just take, I don't know, 15 minutes and look, and you can tell, does she need assistance? Is she incontinent? Is she whatever? They'll have that, and you just got to look at some of the sheets, and you'll be familiar. But you'll see some of these definitions and abbreviations. But I want y'all to write these down, and y'all might already have them written down. Do you? Page 242, BP, what's that stand for? Blood pressure. So y'all can write that wherever, but it needs written down because you will see this on your test. CVA. CVA, that's what I want on the test. It's got to be cerebrovascular accident. Don't write stroke. I need to know. No, cerebral. Yes, CVA. And a lot of people do try to put cardio. Do not put cardio because it's a C, but it's cerebrovascular accident. That means a stroke. That means something happened in the brain. Most of the time, a clot or aneurysm, something like that. Stroke. PPE, what's that stand for?
Personal protective
Equipment. Yes, your gowns, gloves, goggles, depending on what you're about to do. T, y'all better get this one. Temperature. FF. Force fluids. DNR, which is very important in your nursing homes, means do not resuscitate. Sorry. But it's do not resuscitate, meaning if they pass, if they die, if their vital signs are 0, you do not try to give them CPR. Do not resuscitate.
What? Know all this?
Hmm? Yes. Yes. I'm giving y'all ones to pull out. HRB. Head of bed. SOB. Shortness of breath. That's very important. A lot of people want to say side of bed or something else. SOB. Y'all know what that stands for. Y'all don't put that in Y'all don't put that. You was gonna say it because the head of bed, they go straight to side of bed. But it's shortness of breath. And none of that. I've had some questions, people can't figure it out. You know what answers I got. SOB. And income tax time, I get this one wrong a lot. HOH.
H2O.
Nope, HOH. Think about every 85% of all elderly, they are HOH. Huh? What's the answer? I can't hear you. I can't hear you. Hard of hearing. HOH. Get that in your head too. You will see that more often than you see most of them because they want you to know that you might have to, the word, you don't talk louder, you do not shout, you change your tone of voice, you go deeper. Test questions, you're not talking louder and you're not shouting. You will just lower your tone of voice and speak slower, clearer, so they can read your lips or hear you better. But never shout, never talk louder. That's a trick question. Even though I know, huh? You say it a little louder, huh? Say it a little louder. We're not gonna do that. We're supposed to tone our voice and speak clear, slower. FOB. FOB. And you might see that somebody had knee surgery. So you need to raise the FOB. Foot of bed. FOB. ADLs. Y'all know what this means. ADL. I hope. There you go. Our CNAs. That's what we help with. Activities of daily living. That's a magic word for CNAs. We help with their activities of daily living. And we want to know their activities of daily living. We need to know, how do they do their ADLs? Are they independent of their ADLs? And that's how they'll talk. Those are the language they'll use when you're asking questions and when they're telling you about your patient, that they can do their own ADLs. You'll be like, okay, amen. That's what you want to hear. CPR. Y'all probably know that one. CPR, cardiopulmonary resuscitation. That is a wonderful thing.
Do you certify that?
I do not, and I'm disappointed in myself because I was supposed to take that class, but they keep on putting it at odd times. I'm gonna get it this time. Just get it so I can do the class. But there's a young man. He charges $50, I think. I can't remember, but he gives this class a little discount. I think it's normally higher than that. But look him up on Facebook because I can't find it. I thought I had his number, but his name is Calvin Fisher. He does a lot of people's things, and I just send all y'all that way. If y'all can get it done at your job a little quicker, here's his phone number: 421-9830. I told him I needed his cards. 421-9830. Eventually, I'll be doing it. So by next year, when you have to re-up your CPR, call me. Come back to your own alma mater and come back and get your CPR. And I keep y'all up to date on everything that goes on. But you do need your CPR. They're going to ask you to get your CPR if you have it. When my CPR did go bad and I didn't realize it, I went right online, and there's an online one that you can take, but you can say you've got your CPR, but they're going to make you take the real one because that little online one don't really count. But you can look that up too. And I used to have that. I'll have to find y'all that one as well. It's a good one, but it's CPR. O2. What's O2?
Oxygen.
They may have oxygen, right? And you'll see O2. O2, 3 liters. You don't adjust oxygen, but you might want to make sure that you haven't messed it up or turned the knob or any of that in the above as you're working on the patient. PRN. As needed. So they may need to walk as needed. Walk in the hall 3 times daily as needed. And that's what we'll get. We'll take them and we'll walk them 3 times daily. But that's to make sure PRN. Telephone communication. We want to identify yourself. I'll say Turning Point C-Wing, Cheryl Davis, may I help you? So it's Turning Point or wherever you're at. C-Wing, that's my department, my name, and I always say, may I help you behind it? But I always tell where you're at, your name, and may I help you? And then they'll tell you where they want to go. But every phone call we have to answer like that. Because it may be the CEO that's checking us to make sure we answer those phones correctly. I called somewhere one time and I was just so disappointed. It was terrible. It wasn't even healthcare. Burger King. The man answered the phone. He was like, hello. I was like, is this Burger King? yes, it's Burger King. I said, well, and we were sitting at the drive-thru for about 10 minutes. I said, we got 3 cars back here at the drive-thru, and we've been waiting a while. You know what he told me? We'll just go home. Go home then. Oh, I wanted to go in there and fight.
I know you did.
I was just trying to let him know maybe their machine was broken, they couldn't hear that we're there, whatever. But he was so rude. I got up to that window. He tried to tell me to go park over there so they could get everybody else's orders. I was like, I'm not going anywhere. I need to speak to the manager. All that and the above. And then the manager got on there, and, well, I don't know who it was. I said, somebody needs to take control of this because I'm about to call the owner. I'm not crazy. Because he was like, he was the owner. I mean, the manager. I said, but it wasn't me. I was like, oh, this is not who I need to be talking to. And not professional at all. But anyway, make sure you answer the phone. That is your, that's the lifeline of the company. I don't even like Burger King anymore. It just gives me a nauseous feeling. I don't want to go there. But make sure you do that. If you to put somebody on hold, make sure you got the hold button or you're covering it. You don't put nobody on hold because they can listen to everything that's going on in the nurse's station. I mean, you know how you just set a phone down, hold on? You don't do that. If they have to leave a message, make sure you write down the message. Don't tell them most of the time. You can't tell them if the patient is there or not. You'll say, can I get a message? And if they're here, I'll get them to call you back, or I'll get their nurse to call me back. So you get their name, number, give it to the nurse and let her take care of everything. Try not to answer the phone because you're probably going to get stuck with doing something like that. And just let that nurse be there because the nurse will answer 1,000 questions from your family. But that's what they're there for. Thank the person. Make sure you say goodbye. See y'all later. Call lights. You must leave call lights. That is the most important thing in that patient's reach. If it's way over there, you have not done your job. As you leave out that room, that call light has to be in their hand or in their reach. And for CNA purposes, it means in their hand. So they can just, and you just really hate for some of them to have it in their hand. You'd rather put it way over there, but you still put it in their hand. So they just have to use this little way to just mash that little button. Describe barriers to communication. All kind of barriers depending on what's going on with your patient. Resident does not hear well, so make sure you have a pleasant tone. Lower your voice or lower the tone of your voice so they can hear better. Speak slowly and clearly. If they are difficult to understand, just ask them to say it again until you get it. Sometimes, and the first time I went to this one nursing home, this is a young lady. It was not a young lady. I always call them young ladies. An old lady in the nursing home. She just had a stroke. I didn't understand a word she was saying. And I felt so bad because I asked her to say it 3 or 4 times. I told her, I said, I just can't get it. Hold on. So I got her CNA and she came back. She said the same thing to the CNA and she got it just like that. You get to know your patients. You get to know their language. Their slur, their whatever is going on with them. You get to learn it. And I mean, she just knew what she was asking for. It might be something she's always asked for at a certain time. Who
I got
knows?
one that asked for water, but she means lipstick.
Lipstick. There you go. See that right there. And you know that. I'll be over there trying to give her water. Somebody's got dementia. Yeah, better happen. The NA or resident or others use words that are not understood. Just try your best not to use too many big words. You use regular words. And y'all know what regular words, medical terms are medical terms. You try to, we call it lay talk. Sometimes you get to talking so much medical you don't realize that you've upgraded your speech. But try to make sure that they understand what you're saying. NA uses slang or profanity. You do not use slang or profanity. What kind of question? Describe barriers. Okay, it's a barrier. So don't use slang or profanity. Don't use cliches. Never say everything will be okay, because guess what? They may not be okay. So find some other encouraging words instead of trying to tell them that they'll be fine. Okay. If the NA responds with why, when a patient says, I don't want a bath, you say why. That puts them on a defense. Just ask them, a whole nother question. When was the last time you had a bath? But do not ask them why, because it just puts you and anybody else on a, you can tell me you're going to be late for class, why? You're like, I'm telling you I'm being, it just puts you on some kind of defense. Same with them. Try not to ask why. You never give the advice. Try your best to answer, get questions that are long, but if they cannot speak, that you want a yes or no answer. If one finger yes, two finger no. Some way you need to learn to communicate. Even if they've had a stroke, they can't talk. Can they blink? Can they, and maybe they'll come back. Hopefully they'll come back. But you got to find some way to help communicate. And those are when you ask the yes and no questions. Any other time, you ask a long question. I say long question, but open-ended questions that they'll list things, or they'll say something other than yes or no. If they speak a different language, of course, we're going to get an interpreter. If they use nonverbal communication, make sure that it's just expressing that you're there to help. You don't want to use the wrong expressions, because they catch on. Sometimes these patients, it's their body that's messed up. It's not their brain. You got some very smart people in nursing homes. Their body's messed up. They hate they're there, but they're there. And trying to make the best of it, but don't downplay their knowledge just because they're in a nursing home. A lot of people have defense mechanisms that can mess them up too. And that's just that happened. I tried to tell my baby today, and she got all in my, she acted like she was a 16-year-old. My baby's 25 or 26, and I was telling her, she done lost the car, she done, she needs to go find a better job. All the good stuff that a mother getting on her 26-year-old should be saying, get it together. And she just, but she's got it's like automatic. She just turned off everything that I was trying to say, get it together, or let's do right, to you just talking bad about me. I was like, oh, that's not what I'm saying. I'm saying you need to get together. And you ain't together, but I'm not trying to make you feel bad either. I'm not trying to make you feel bad. But she went straight there. But that's her little defense mechanism. So trying to make me feel like I'm not changing my story. This is what you need to do, and this is what's happening wrong, and you just need to fix it. He just made me feel like I ain't done nothing right my entire life. Then she goes straight there to your hurt, not feelings. Not, yeah, you right, mother. I ain't right, and I need to get it right.
Will she come back later and say that then?
Every once in a while. She might even post it. She'll post it on Facebook. I know I get mad at my mom, but she tells me the right thing, But I told her, she's too old for that. I said, I want to go visit you at your house. It's about that time. Instead of you losing a car, you ain't paid a. I said, you ain't paid a car note. Not car note. You hadn't paid rent, light bill. You should be wallowing in money. She don't want to hear that. Well, I got this, and this. Yeah. She done spun out, I don't know, $3,000 trying to get her license back from driving suspended, because the first was seatbelts. Seatbelts that she did not go pay the ticket for. Then she got a license suspended, driving somewhere else, didn't realize they suspended, so she got a suspended driver's license. They didn't pay that, and I'm like, this is crazy. Crazy stuff. But anyway. Oh, it's crazy. I told him, you are too old for that. You're old now. But denial. That's part of her problem, denial. Especially saying, that's not really what you're saying. You're saying this. Projection, seeing feelings in others, that's really your own. That's what I told her. She said, it's like you're saying. I said, did you hear what you just said? It's like you're saying. I did not say that. This is what I'm saying. We even had the cleaning lady that was going to help clean the house today. And I really needed her. Because I don't call them but every 2 months or so. And I just be like, I need some help. And she just left. Politely left. She didn't say a word. No. Where'd the lady go? And that's what she said. She said, y'all was getting a little too heated. And my baby went a little wild on me. But those are defense mechanisms. Sorry. Displacement. And that can happen. You're mad at your boss. You're not going to cuss the boss out because what? You need a job. You would love to. Choke them. Meet them out in the parking lot. But you don't do that because you need your job. But then you go home mad, upset, and you go take it out on other people. That's displacement. Rationalization, everybody does it. I'm going to do it too. Everybody's late for work. I might as well be late too. And I fell into that trap, right? They do it. I'm doing it too. Because that was not my values. That was not my ethics. I was the one on time all the time. But I said, well, they're not in trouble. I'm not rushing no more. And I did. And had it. But don't be that person. I don't like them people. So I got it together. But I did. I said I was going to be slack. And it probably did about maybe 6 months. And that's really not me. And I don't want to be included when you're talking about people who are late. So let me be back on time. But yeah, everybody does it. So do you. That's what, and that harms people's thinking. Repression. Sometimes that's a good thing. Say you were raped and you repress it. That means you kind of stuck it back in your brain. You don't think about it. It's there, it's still there, but you don't think about it. It's kind of like you just tucked it away, and that's what it is. In that case, that's a decent thing. Some kind of most time it's a trauma that somebody's been through and they just took it away. Regression. That's acting like a child when you're a grown person. That's what she did. I should have used that word on her. Regression. For example, throwing a temper tantrum as an adult. I've done that several times as an adult. That's when you get to throwing things. That's when you get to hitting things. Those are really just somebody having a temper tantrum. Break things. I'm trying to throw things. That was my thing. Try to break something. But those are regressions. Just know that those are problems to communication. If somebody feels this way or gets that way, you can't rightfully contact with them and connect and try to help them fix their problems. Culture can also affect communication. Where are you from? I have a friend from Canada. She likes to talk to me right here. I can't even see that close up. I don't want you breathing on me. But she talks to me like this. I said, oh, Canada people act like that. I need some space. She's like, I didn't realize. I said, oh, I think maybe French people do that too. They're always kissing and stuff like that. That's just not how I was raised. It's a little uncomfortable. I don't think there's nothing wrong with it. It's just, I got my little space. I want, when people sit behind me, I don't like that either. I do not like that. In class, it never bothered me. I don't know why. But grown up, that's what I feel. Somebody behind me. And it just, I'm like, can you come on up this way? Or I'll step back. I don't care where we're at. In line, it's fine. It's just like standing somewhere. I can't even give a good example right now. But, that is how some people are. You've got to learn that person. Americans are not as close up. Always reminded of South Park. Y'all seen South Park? You probably have. You done seen South Park? They're terrible. It's the little cartoon people. But how do the Canadians look? The people from Canada. That guy that's got his head unattached. You know how everybody else talks like this with their mouth? Yeah. The Canadian's head, it just goes up and down. And I always use that. I said, in my Canadian friend, I said, that's why they did that to y'all. On South Park. Somebody knows that y'all are a little different. But, y'all ain't noticed that? The guy from Canada, his head just is not attached. He talks like this.
I don't know.
Everybody else talks, you know, they got them. Just look at it again. You'll see the ones from Canada. They come, the head's not deep. It's like cut in half right where they talk at. Anyway, y'all supposed to know that. But that's why they are. But just know that gestures, things, that's their culture. And it doesn't mean Indians. They respect you looking in their eyes. So do we. I think it's maybe Japanese or Chinese. Don't look in my eyes. You feel on the same level as me. And most people are not on the same level. So that's why they always doing this. They got their eyes. They're not looking straight at you. I kind of don't look at people, period. Because I'm half blind anyway. And I've always felt uncomfortable, not teaching and stuff like that, but like out in public, looking at people. You might walk by, I won't even look at you. You better say, hey, Miss Cheryl. Because I just kind of, one reason is because I can't see, period, because I'm looking forward. But, yeah, if I ever see y'all, make sure y'all say, hey, because I'm probably not looking. That's my culture. That's not my friend. She's in everybody's face looking at them. and, you know, that's just her.
Yeah.
Knows everybody and knows when they come by, and I get mad at her. Hey, and we'll be passing them, and she'll wave at somebody. It's like, who's that? She'll be like, da-da-da. I said, why you didn't tell me? Because I'm not looking. I could have waved, too. They probably think I don't like them no more. And she'd be just, you know, I'd be like, who was it? Make me see. But anyway, that's some people's culture. That's how they are. And just know that. Guidelines for communicating with patients with an impairment. Impairment is a loss of function or ability. Depends on what their loss of function is. They may have a hearing impairment. What are they going to be wearing a lot if they have hearing impairment? That hearing aid. I don't know how to take care of every hearing aid. A lot of them we can clean with soap. Some of them need a special solution. Some of them need charged overnight. Some of them have their own little charger you just sit it on. You have to read instructions. All this stuff, read the manufacturer's directions. That's what I need y'all to understand. But most of the time, and all the time, we're going to remove it before bathing, showering, or shampooing their hair. If they're bathing, shampooing, or showering, any of that, we're going to remove that hearing aid. So just make sure you don't want to mess up anything. And we're going to protect them hearing aids. And some of them are so little, some of them are bigger. And it really just depends on where they got it from. For hearing impaired, you want to reduce or remove noise. And for that reason, it distracts them. Other noises distracts them. They can't listen to you or listen to the TV. They may just want to listen to the TV, but all this other noise is going on. If they can lower some of that, then they can hear the TV better. You know, people having a conversation over here, and they'd rather just go somewhere and listen to the TV. But distractions will do it. I always get their attention before speaking. Don't startle them. Sometimes people can't hear you, and they can't hear you when you walk up on them. I have a terrible reflex. You know, I jump, and then might want to hit you. You know, somebody come up behind you. You done scared me. You know, you're just sitting in your car or whatever. Somebody come up through the window. You know, that scares me. I'm about to jump out and fight, but before about 1 second, I'll figure it out. But it's a reflex, so be careful. And when you're doing people like that, they can't hear you. You done walked in their room and they still don't know you're there. You know, hello, or knock on something. They do vibrations. If you tap them, use your whole arm's length, because they may be that person that just can't help it, and that's what you do. And you're scared them to death. Have you ever been scared? And you know, oh, sorry, and that's what you got to do. So, long hands, tap your patient. Try not to do that to them. When you are speaking to somebody who can't hear, you want to let them look in your face. So they may be trying to hear and read your lips. So always look at them straight up. Do not shout. There it goes. Do not mouth the words in an exaggerated way. I had one patient, and that's what I did. I was like, hello. But You know, and I know he's reading my lips, and I'm just, you know, doing